I've got some notes to introduce you, but I can leave it to you.
It's not much to say. I'm another oncology specialist. I think you've had a weekend full of great specialists who I'd call friends, colleagues. I've been here quite a few years now. And yeah, this is your floor. Please fire away. Nothing's, well, relatively nothing's out of bounds. So yeah, here you go. Over to you guys. I was going to say, we don't normally have a shy audience, but yeah.
I've got some questions as well.
Okay. I think we got a few.
Yes, that's okay.
Yeah.
Because we asked people who couldn't attend to send their questions in, so I will.
Okay.
I'll take those. That's all right. I'll take all that lot off you. You just focus on there.
Just a question about seizures and TKIs. Is there any information that shows how many people have seizures while taking a TKI? Is it something you've come across?
Do you mean as in the drugs themselves, or because there may be treatment or things going on in the brain side?
No, the drugs themselves. People who've been diagnosed, they're diagnosed with a brain met, they're symptomatic. Have you got any experience of people having seizures while they're taking that drug?
Personally, no. I mean, usually, in my experience, the seizures are driven by what's going on in the brain in terms of if there is spread in that area. It's the irritation or the swelling that causes that. And usually, because of the drugs we can use and the responses we get in the brain, usually those aspects, patients will often present with a seizure. But from my experience, that tends to be it once we get the treatment started and get the swelling down within the brain.
Are you aware of any data that exists as to people that may have had seizures whilst taking TKIs?
Is there any specific TKI you've got in mind, or?
No, all of them. Well, all of the current ones.
I'm not aware of. I can have a look, but I'm not aware of that. As I said, I think if seizures are ongoing, there's probably got to be, from a clinician's perspective, first of all, to ensure that there's no interactions with other drugs that the patient may be taking, but also a deeper dive into what might be going on in the brain as well.
Okay. Thank you.
Okay.
One of the questions that a few of us have had for a few years in the community is the size of our community. We know that about for every 100 lung cancer patients, about 85, 90 will be non-small cell lung cancer. And of those, ALK in theory is about 4% or so, EGFR is 12%, I think ROS1 is 1%. Do you see that in the real world, those sort of percentages in the real world?
No. We believe, at least in the UK, 4% is probably an overestimate to what ALK is. I know that's kind of globally, the data, the pie charts I show also put it around that. I think the reality for the UK is probably about half of that is, and it's bizarre, and it's not to do always with demographics. It's certain postcodes, you'll see a flurry of patients, and we call them the bus arrives. You might get 5 patients with a driver mutation in a row and then not see anyone for 6, 8 months. So the numbers are probably lower, and is that because of obviously element of non-diagnoses as well? I know Deborah and the group are doing a lot of work about making awareness of cancers in non-smokers or minimal smoking history. So, but I don't think it is purely that. I think the global figures don't always reflect, and we've seen the same with EGFR. We did a big data set or look at our own, and we're probably around 9% rather than that 10, 12% that you typically get quoted. But again, it depends where you work and what population you're serving.
Okay, thank you.
Okay. I think the other thing to add to that is, and I see that with my own patients, that I think this is a great forum, and I always talk about it to all my patients, but not everybody feels they want to engage with it as well. So you may not see every patient coming here. I think people do have different perceptions about, or maybe they just want to look on the sideline and see what's going on, and maybe not, come to the, or be as involved as you guys are. And I think everyone's individual from that perspective. So you probably don't, and I know that from my own patient cohort, that not everybody engages fully with the charity.
Thank you.
Hi, good afternoon. I've got a question about side effect control, and it's about whether we should be managing side effects with dose reduction or medically. So we know that the median PFS for alectinib is only 34 months, and I've been on it for 65 months. Did have a bit of radiotherapy for reactivated lesion about 2 years ago. And I've been having a long conversation with my oncologist, so I've got a bit of hepatotoxicity, not a lot. My ALP sticks around about 190. I've got myalgia, I've got really massive gut issues, so I would say that I had stage 4 diarrhea, which has a massive impact on my life, and I've had it for the last 2.5 years. And I have managed it medically with loperamide. Now recently loperamide's making me sick because I'm taking 8 tablets a day, so I'm thinking about how do I manage this. And my oncologist is very open to reducing my dose, but extremely cautiously. So at the moment we've gone down 1 tablet a day. Okay, so went on holiday a while ago to Greece, and I decided that I was going to go down 2 tablets a day. So I took a 3/4 dose, and all of my side effects, all of them disappeared. Okay, and when I came back, I admitted that I'd done this, and he said that was very good management for a short period of time. Now I want you to go back up. However, we are still in this limbo period where he's now suggesting that I stick to reducing by 1 tablet a day on an otherwise full dose. And when I go on holiday, I can go down to a 3/4 dose. But it feels to me like nobody is willing, myself included, to take responsibility of if you have a progression on a reduced dose, what do we do? So we don't seem to be able to have that conversation. So am I better to continue to treat medically my side effects? I can't treat the myalgia, that I've either got that or I have not got that. I can't treat my liver issues. I have no control over that. I can treat the diarrhea, those being my 3 main ones. So what is the best thing to do? And if I was on a 3/4 dose and I had some progression, is the first thing that you do to go back to full dose?
There's a lot in there, isn't there? Okay. So let's break this down. So the first thing is, how are drugs approved? So the early phase studies are done on the premise of the dose-limiting toxicities. Drugs go up in scale in those very early phase trials to the point where somebody can't take it anymore. Then it goes down 1 dose, and that's the drug that then moves, or dose, historically, that then moves forward into the next line of studies, or next line of trials. But that doesn't mean that that's the most effective. It's the one that was the most tolerated. And we've seen that with a lot of drugs. And you know, there's a question mark about lorlatinib is, you know, what is the right dose that should have gone through? And obviously, and hence this question mark about being on that full dose. Yes, okay, that's the dose that people tolerated in those early phase studies, but it doesn't mean that if you were at a lower dose, could that have been just as effective? So that's the first thing to bear in mind, that it's not, the dose that goes through isn't necessarily the best dose. It's just the one that could be tolerated the best. The other thing is there's been a lot of trials now where the companies have gone back, or the sponsors have gone back and then looked at what happened to people who had dose reductions. And we've got to take that kind of data with a pinch of salt, because it wasn't what we call the prospective analysis. So it's not statistically as significant, but it's useful for us as clinicians, and it's useful for the community, or the patients. And what we kind of consistently see is that the lower doses don't seem to do worse. And if anything, there's a question mark, do they do better? And could it be because they're able to tolerate the drug for longer, stay on that dose for a longer period of time? Having said all that, I would still always look to start on the prescribed dose unless I had a reason to go on a lower dose. I think the right thing is always to try and manage side effects with supportive measures, medical drugs, counseling patients. But then there comes this balance between, clearly what I would say you're describing is, what's the impact on your quality of life? And how are you tolerating it? And have you maxed out on what can be done from a supportive measure? when you do reach that perspective, I am quite comfortable with dose reductions for the reasons I've already alluded. And it's about what your body can cope with, what your body can take. And that's how I counsel patients. I understand it from your perspective or from that side of the table. You're cutting down on the drug that's keeping me going. But I always say, but it's what your body can tolerate. Think of it that way. And the more you keep going at that dose, your side effects are adding and adding. There may come a point where you just need to stop or have a prolonged break, which I would find more detrimental than actually a dose reduction that then keeps you on the treatment indefinitely. The final bit that I was going to say, will it come back to me? There was one more point I wanted to make. Bear with me. No, it's gone. That was it. That was the one. I knew there was something. So from my perspective, if you've been on a dose reduction and the treatment stopped working in a way that, as an oncologist, I felt, and you've had a great talk with Clive about what happens with oligoprogression. We're not talking about that, where you've reached a point where things have grown and you need to change treatment. To me, the cells are now resistant. They're resistant to that drug. So upping the dose, getting more of that drug into you is not going to suddenly turn that resistance, and that's not the issue. The dose has been in you. I mean, if you started on if you were, for some reason, the oncologist felt you had to start on a really tiny dose and then you got stronger and better as the treatment got on, that's a different reason. But if you had to go down a dose, things have still been maintained and then things got worse, increasing the dose, in my perspective, wouldn't make any difference because of that reason. So you are then better off switching. You got your money's worth today, didn't you?
The microphone on. Okay. Could you talk to us about vaccines, anything that's coming to the UK that does include ALK? Because I've been asking my professor about it and nothing seems to include ALK. I know they're doing it in America, but that's a long way off coming to us. And if there's any other trials that you know of right now or that are coming that will include us in an arm.
Okay. I think vaccines are tricky. I know there's been a lot of buzz about ALK vaccines. There's the longevity, there's the Moderna stuff that's going on. The difference with ALK compared to others, and that's why you don't see this flurry of vaccines in kind of the ALK or even the EGF or that driver mutation space, is that we find that compared to other, or the other typical lung cancer, those that don't have the driver mutation, it's not as immunogenic. We're struggling to get the immune system to recognize the tumor as foreign, which is why immunotherapy, at least on its own, doesn't seem to have any benefit. I'm not aware of any of those, and all those studies that may have included ALK, as far as I'm aware, they weren't specific for ALK. They were just studies that were kind of all-comers, but if you've exhausted your options or been treated with your targeted treatments, you can then go into those studies. So I'm not aware of any of these coming to the UK at the moment. And I think they're very early in their setting. In terms of what is going on, obviously, I'm sure you guys all know about Nuvalent. There's obviously the Nuvalent trial. There is other stuff going on, and there's another class of drugs, something called the ALK glue inhibitors, or degraders, which is a different class of drugs that may be entering the ALK field. There's a lot of interest in that class of drugs. They're very early in their development. Whether these studies come to the UK, we never know until they actually come to, or come forward. The sponsors have to choose the UK as a site. We usually are an attractive site for companies on a global level, but we never know until they happen. It depends on the study and what the premise is and what phase it is. The earlier phase studies tend to be limited to certain countries, especially things which are complex, like the vaccine ones, where at least the Moderna one is a personalized vaccine, so each patient that goes into it, it's personalized to them. So obviously the resources and logistics for them are quite complex.
I've got a question for you, from someone who wasn't able to attend. So, in terms of after progression on alectinib, would it be possible to skip lorlatinib and go on to the Nuvalent fourth generation TKI using the extended access program? There are some patients in the US that have skipped lorlatinib and are now going from alectinib to Nuvalent?
Okay. My thought would be, because of the way access schemes work, it's probably going to be unlikely, because access schemes usually work on very strict criteria of you've exhausted all treatment options or targeted treatment options. Now, could you put a pitch that somebody is intolerant to lorlatinib or something? That could be a different context. But that's for the early access scheme. In terms of what would be the benefit of doing that, I mean, I guess if we do look at the trials or the ALVOC study readout for the early, the numbers were very small, but it does seem that if you are LORLA naive, you may get a higher chance of responding. But those numbers were very small, single-digit figures, which are very small to interpret. So, I mean, it's a difficult one to answer. Whether you could access it or not, the only way you would know is your clinician putting a case forward for you for the program. We don't have control, and they have very strict criteria, and it's literally tick box, but sometimes you can have a bit of, or put an extra pitch in if there's a valid reason to skip something. Is it the right thing to do or not? It's difficult. As you can see, the way treatments evolve, the better drugs tend to move up the algorithm, and Nuvalent obviously is also being looked at potentially soon in the first-line setting. So as an oncologist, yes, I always like to use the more powerful drug higher up. Will we ever get that bona fide data about which is the right sequence to go for? I don't think we will, or it'd be very difficult for those studies or to get big data sets on that. So yes, I guess there is a attractive pathway to do that. Whether it would be feasible, I don't know. And if Nuvalent ever got reimbursed, again, it depends on how NICE would look at that and what the wording would be, which would be pretty stringent, my guess would be.
I wanted to know if there is any evidence of chemotherapy with TKI combination, chemotherapy before taking a TKI is more effective.
Before taking, as in at diagnosis?
First chemotherapy,
right,
and then TKI. Is it more effective? Is there any evidence?
No, the only evidence we know is if we go back to the very, very first studies of when crizotinib was first approved. So it wasn't really a sequencing, to be honest, but crizotinib got pitched. So that was our first generation drugs. Many of you may not know that now, but this was many years ago when ALK, that was our first targeted drug against ALK. So that was pitched up against chemotherapy. And it proved, that was the first time that we saw that there was the targeted approach is better than chemotherapy. When it first got approved, actually it got approved in the second line setting, so people had to have chemotherapy. And none of us as clinicians wanted to do that. So dare I say, we used to give placebo chemo to get them through chemo, so we could get them straight onto their ALK-TKI. Chemo as a first-line treatment, no, and it won't make the ALK drug more, it won't potentiate, there's no biological rationale why it would make the ALK drug more effective. So really, you do want to get, again, back to the last point I made, you want to get onto your best drug. I'm a big believer, use your best option up front.
Right, so I'll ask another question maybe after this. Thank you.
Yeah, sorry. If you've been, if you have bone metastases on initial diagnosis, and you're put onto Zometa in the bone strengthening treatment, what are the protocols and what are the recommendations on how long you should be taking that? Should you continue to take it indefinitely, or what are the protocols and the recommendations for that?
No, and to be honest, Zometa's now been superseded by a drug called denosumab, which should be your kind of bone strengthening drug to go for now, or your clinician should be using, which is a subcutaneous injection. But no, so the premise of giving these bone strengtheners are once the cancer's gone in the bone, unfortunately that can then affect the integrity of the bone, the strength of the bone. So we want to keep that integrity or the strength up. There is also some data that these remodeling can also slow down the growth of the spots in the bone, but obviously we rely much more on our ALK drugs to do that. But no, once a patient's started on, unless there's an issue related to it or side effect, it's an indefinite one.
Question following on from yours. It's slightly different. It's turning the chemotherapy after. So I've got a question that's come in from one of our members. Alectinib was working for me for 5.5 years, and then the cancer spread. The oncologist stopped the alectinib immediately and started lorlatinib. I know you've got limited availability of information, but could radiotherapy or chemotherapy with alectinib have been better than just moving to lorlatinib? Lorlatinib has now only worked for 6 months and the cancer has spread again.
Like you say, it's difficult with the information that we've got. It depends what the progression was. Could more have been squeezed out of alectinib? I definitely wouldn't have combined alectinib or with chemotherapy. I think the right thing would have been to switch to lorlatinib. The question mark is whether there would have been a benefit in a rebiopsy after alectinib. But, you know, for me, again, I'm more focused on rebiopsying after lorlatinib. I think the real question then is what do you do with your chemo? And I'm sure if this question hasn't come, it will come, is can you keep the lorlatinib going while on chemotherapy? And I know they like doing that in the States. There's no strong data to tell us whether that is better or not. Biologically, it makes a bit of sense to keep the ALK pressure on, especially if you still, when you've rebiopsied, still see that there is ALK altered within the tumor, that you've not got a different, what we call an off-target mutation. But there's no strong data on that. We can't do that in the UK, well, at least not within the confines of the NHS. So, but yeah, I don't know if that answers that question. I know it's a bit tricky with that information, but no, I think the right thing was done to switch to Lorla. The question mark is now what the next step would be.
Hear from Andy.
It's not actually a question.
Oh.
Graham, would you like to come up as well? We don't get a chance to thank Graham and Deborah for everything we do. I tried to do it last year, but we didn't get us old. Come on up. It isn't a question. I was one of the first members of the group when Deborah started it, how many years ago? 7, 8 years ago? 7, 8 years ago. And I got more involved in the last couple of years. It's been an absolute eye-opener for me. Deborah went through everything that the charity has done. The amount of time, the amount of passion, the amount of knowledge, the amount of effort that Graham and Deborah bring to this is absolutely astounding. So on behalf of all of you, thank you to Graham and Deborah for everything they do for the charity. It's not just a conference, this is a full-time job for them. Thank you.
Yeah. Thanks for the embarrassment. Right, now let's get back onto the business, shall we? Right. Has anyone else got a question? Because I've got a bunch of them here. Yes, there we are.
So we heard from Dr. Pedal that we should be having robust conversations with our oncologists. Now, as a patient...
Define robust.
Yeah, well, in the sense that we should, if we feel that there are other treatments available, that we should be able to have those conversations with them. Now, as a patient, I do have those conversations with my oncologist, but I'm sure that there are new patients or patients here that find it difficult with those conversations maybe. Now, we learn a lot coming to these conferences. We learn a lot from the online pages and the support group. But as an oncologist, what advice would you give to patients that are not in a position to be able to fight their corner or be a patient advocate for themselves at those meetings? Because it can be quite intimidating when you're a patient.
Yeah, I mean, I heard Clive's comment about that, and I totally agree with him. I don't think you're worth your title if you're not having those discussions with your patient. And I always say to patients, if there's something you've seen, patients will, especially you guys, you come very well prepared. And a lot of the time it's stuff about just going through, reassuring, explaining why we're doing this or why we're not doing that. But I always end by telling patients, if you've got something, you want to bring it, doesn't matter how wacky it is, I'm happy to look at it. Don't feel like it's a difficult, I can't put myself in your shoes, but I can just imagine it's a difficult journey. And if you're going through that journey with unanswered questions or uncertainty about your treatment and your pathway, and they're not being addressed, then that makes that journey so much harder. So you shouldn't feel you shouldn't feel you can't. I can imagine there's many different personalities of my equivalents out there, but you will have your rights to challenge and ask questions and seek other opinions if you feel you're not getting the answers you want.
I can ask one. Okay. Can I ask about best practice? Putting aside NICE, putting aside trust rules or requirements, should a biopsy be carried out whenever progression takes place? Without the biopsy, you can't be sure what's causing the progression. Is it still ALK or does it change to something else? So, best practice, should a biopsy always be carried out?
Ideally, yes, but there are some provisos to that. Is what tools? I mean, I'm not meaning just resources, because there's sometimes rebiopsies can take a bit of time, etc. But there is also what's the patient clinically like. If the progression is happening at a rate where there isn't the time to wait for that rebiopsy, then you may just want to get on to your next treatment. In terms of second generation, so alectinib or brigatinib to lorlatinib. Again, if I reach the point where what I tend to like to do is rebiopsy while things are, often in these scenarios, but not always, the progression happens over a period of time, and it may not happen at a point where I feel I need to change treatment. But so you've got a bit of a window of opportunity to say, well, I'll tell you what, we're not jumping ship yet, but shall we think about a rebiopsy? So that's a controlled way. Most of the time, post a second-generation drug to lorlatinib, it's unusual to find something that may change the treatment. But definitely after lorlatinib, for me, as long as there is the time to wait, that is a must-do to be rebiopsying. As long as, I said, patient can clinically hang on, and there isn't the urgency to switch treatment. And ideally, you should be talking about a tissue biopsy, and that's because sometimes the cells can change from, most of you, if not all of you, will have what we call adenocarcinoma, but that can sometimes change to a different type of non-small cell cancer, or sometimes even a small cell cancer. So blood biopsies are great. They are a phenomenal tool to look for mutations, but they won't tell you about that change. But again, it depends on what tools you've got, how easily accessible they are, what are your resources, what are your weights for rebiopsies. But then you'll remember, rebiopsy happens. It can take your lab a couple of weeks to turn around that result, especially for the extra mutations that you may want to be looking for. So it's not always that easy, even if it was best practice. And with the best of pathways you've got, you're probably talking about 4 to 6 weeks to get that biopsy and the results of it. So you may want to just switch your treatment and then wait for that result, and then maybe switch depending on what that might show.
Okay. Question here.
So currently, ALK is staged the same way as all non-small cell, which can sort of, most people diagnose stage 4, and which closes off some sort of like the radical treatments on the NHS. Is like that when it's advanced, given how differently and how long people can stay on treatment, do you think there's scope to rethink staging specifically for ALK or other oncogene cancers?
Interesting question. In all honesty, I don't think that will happen. But what I think does need to happen, and it doesn't have to be an ALK-driven mutation or a driver mutation, is you need to have an oncologist or a team that don't close off doors just because of the stage. And we do that quite a lot of the times. And I think I only caught a few of Clive's cases, but I've had patients who present with a brain lesion and a localized lung cancer. So we think, well, if we can radically treat the brain, why can't we radically treat the primary? If there's a solitary met, why can you not? It does help if you have a good drug treatment to consolidate that radical treatment with, because of the what we talk about, those microcells that are probably lurking around to have caused the spread in the first place. But no door should be closed because of staging, and how we treat oligomets, etc., is a good example of that. So I don't think it will, and as I said, and the reason for that also is because I would do that even for my non-driver patients if I thought, I always say it's about the biology. If the biology looks favorable, and the kind of the stage or the spread is in a confined way that you can push the boundaries, then you should. And you need a good engaged team as well around. You need good radiotherapists, you need a good surgeon to be engaged in those discussions.
So over the years, on alectinib, I've become more exhausted and achy. It's like having the flu without the fever all the time, and some days are actually even worse. So my energy needs improving, but exercise is exhausting. I well understand all the usual exercise advice. So that can ADHD medication help with this or anything else?
I don't know, I've not heard of that, but I think that sounds to me like a very, going back to the lady's question there is, has this patient reached a point where dose modification needs to be thought of?
She's on the minimum dose. I know this lady.
Okay.
She's on absolutely minimum dose.
Minimum dose. I mean, beyond that, I mean, the things that exercise is a big player. I don't know about ADHD drugs, I'll be honest. We do use courses of steroids to give people boosts occasionally, but that's not a long-term fix. Even when you're on the lowest dose, there's other things you can do, but obviously then you are in the realms of what are you doing efficacy-wise? Can you do alternate day, etc.? But that becomes, a question. It really depends on the impact on quality of life that's going on here. But it is difficult when you reach that bottom dose, and it's those toxicities that we don't see. The bloods all look great, the scans look great, but the day-to-day living, I can imagine, is difficult. That's a difficult one and you really need a good conversation with the oncologist about that.
Okay, right. I've also got another, I know I feel I'm hogging the stage here, but while we've got some questions that have come in, it's from us. What can be done to help people get diagnosed at earlier stages than stage 4? What are your thoughts on?
All the work you're doing, I think. Obviously, for the smoking or those that fit in the lung cancer screening, that's a big bonus. But for a lot of the outpatients, because of the smoking history, not being diagnosed with COPD, and obviously age as well would cut you out from that. Apart from the awareness work that you're doing with primary care, and again, just I think public awareness as well, that just because you haven't smoked, if you have got those worrying symptoms, you need to seek medical attention.
Anyone got any more? No? Oh, yes, we have, sorry. We've got questions over there.
The FLORA-2 study for EGFR showed that there was a progression-free survival benefit for combining chemotherapy with first-line osimertinib compared to just osimertinib on its own. I appreciate that you can't necessarily extrapolate that across all of the other driver mutations, but do you see that as a possibility for, I don't know, 5 years, 10 years in the future or whatever, for other driver mutations when the studies have been done?
So recently so that's also gone into an overall survival benefit as well. So, but I don't think so, and there's two reasons for that, not for ALK anyway. I think one, you've got to bear in mind that although we're doing good in EGFR, the EGFR drugs are nowhere near reaching the PFS or OS that we're getting in ALK. So osimertinib, the median progression-free survival is around 18 months. Alectinib, brigatinib, you're up to 3 years median, and then lorlatinib is well beyond that as well. So, and there's and look, FLORA-2 is great, and I was in that trial, we participated, I've got patients on that regime now, and it is good, but the chemotherapy does add a burden, and it's how long are you going to be on that chemo for, because the chemo, you hit hard for 4 cycles, but then you're on a maintenance chemo indefinitely. So I think that's a game changer for EGFR. Also, we're not seeing this kind of next generation of EGFR targeted drugs coming through. There is a lot of work going on, but more about combining our 3rd generation ones like osimertinib with other drugs. Whereas for ALK, again, the world's evolving in terms of the next generation of ALK inhibitors, maybe other ways of targeting ALK. So for those reasons, I don't think we'll see that same, I might be wrong, there may be some interest in it, but my thoughts are that it will be focusing on the next generation of ALK inhibitors.
Okay, we've got one here.
I had lots of questions, but one is again on the chemo part. So if a TKI stops working, develops resistance, then doing chemo, does it reset the TKI?
So doing chemo is unlikely to do that. So again, it depends what you've done in terms of biopsy pre-chemo to know what's going on. So what tends to, so there are cases where things have changed as the tumor evolves, but what tends to cause evolution, I might backtrack on what I'm saying, what tends to cause evolution is pressure on the driver. So if you've got a targeted drug, that tends to be what drives resistance mechanisms. Chemotherapy as such, chemotherapy, think of that as blindly killing cells. So you're not putting a pressure on on what's driving the tumor. So the tumor doesn't evolve in terms of trying to find an escape mechanism that can then be targeted. The only element that you could argue could do that is we know that changes happen in a clonal level. So that means as your tumor becomes resistant, it doesn't all become resistant in one go. There'll be pockets of it becoming resistant, and then they will evolve, and they will become the dominant tumor within the body. So arguably you could think whereby you've treated with chemotherapy and you've killed lots of cells, that then the dominant one may be the remnants of, so there will still probably be remnants of the tumor that was sensitive to the targeted drug. Not always, but especially patients where we sometimes see areas growing more than others, so clearly there's a mix of different cells going. So arguably, could you then, after a period, your dominant clone is now the TKI. So it's not resensitizing you, it might be just this clonal battle that's going on. But, again, one would be access to the drugs, but it would also be, what's the next step? There may be better options. It's about, where are you in your treatment pathway? Access isn't always there for re-challenge as well. So.
And there's a second question, because I don't see any other questions. So, are there any centralized tissue banks in the UK where you can have tissues, donate tissues, our patients can donate tissues for various types of mutations called EGFR, ALK, ROS1?
Donate as in for research purposes, or? Not that I'm aware of. I mean, there sounds a bit morbid. There was what we call the PEACE study, which was actually, a lot of this clonal stuff that we understand is from a trial called Darwin that was run by Charlie Swanston. And he did this where, I guess, yes, there was that initially. So it was about rebiopsying on progression and seeing, well, what happens next. It wasn't just for driver mutations, it was for everything. He's also done the PEACE study, which is where patients, if they pass, they can donate their body. And again, what they're doing is mapping up all the different tumors to see, well, what is the difference in there? So that's probably the best we've got in the UK, which is still there's been a lot of publications. He's done a lot of work in why never smokers can get cancer as well. So that's it's probably the best we understand it.
Hi. Watching the recent US ALK conference, they discussed switching to lorlatinib before resistance occurs, and one oncologist used a 2-year as a cut-off, and to decide whether or not to switch patients across, and that was from alectinib, and wonder what your views are on that.
God, the US, they're a pain, aren't they? I'm trying to think why you would, is the honest answer. There's no data to tell us that if you switch earlier, you're going to do better on lorlatinib. And as I'm sure there are many of you in the room who are or have been on alectinib for many, many years, beyond 2 years, to me, you're potentially affecting the sequencing pathway. We know, at least at the moment, that all these drugs are better up front before you've used, rather than using them after you've used another drug. So to me, I don't think you're going to get as much out of lorlatinib having done it switching. I don't understand the reason. I mean, you're not doing the CROWN study, you're not doing kind of a sequencing. You're, to me, messing the biology of the tumor up. If there's no resistance developed at that point of 2 years and the patient's doing well, why switch?
Because if they're using it as first line with the evidence that there is.
Say that again, sorry.
Using lorlatinib as the first line with the evidence that there is.
Do I believe that? Or as in, am I...
I think that's what they're doing in the States.
Yeah, no, that's fine. I think as a first-line drug, I think that's totally fine. But if you've already committed to a good drug, I wouldn't switch early for no reason. Now, yeah, I think, the CROWN data for me is very convincing. We are hoping to hear something from NICE very soon on lorlatinib first line. But that's a different, for me, that's a different aspect. Yes, if I had access to lorlatinib first line for all my patients, it wouldn't be for everybody, but it would be my go-to drug. But to start somebody, if somebody's already started, I think to me you're messing up the biology of the resistance mechanisms and you're doing more harm than good.
Thank you. And just a quickie. Another oncologist spoke about using liquid biopsies as a way of detecting recurrence of disease before it becomes apparent on CT imaging. And his approach is then to request a PT scan in the event of a positive liquid biopsy, and wonder what your views on this novel approach is.
So it's not novel as such. So we know this from all the trials. So this is for patients who've had their cancer removed or had curative treatment. We know that there's something called MRD, or minimal residual disease. And all the trials, all the early stage studies that we do with curative treatments, patients are then not just monitored with scans, but they're monitored with liquid biopsies, looking for circulating tumor cells. And we know that they are quite sensitive. Somebody is positive for circulating tumor cells, or what we call minimal residual disease, or they develop that, it's almost a given that sadly the cancer will recur. We don't know the timelines for that, it can vary. But at the same time, it's not fully specific. So it's sensitive, that means if you're positive, you're almost guaranteed to recur. But it's not specific, that means if it's negative, it doesn't reassure you fully. But that's very different. So we don't have those tools in daily practice. Obviously, the US have everything. You pay for it, you get it. But how useful is it? We're talking early stage. The big question is, would it change your monitoring? Would you do anything different if you found it? Patients are scanned quite frequently anyway. It's a topical thing, and it's not just for lung cancer, bowel cancer, breast cancer. These are big. There is very robust data about this, but it's not been applied to clinical practice because at this point in time, it's not thought to be practice changing. And in a similar way, also, sorry, just to add to that, it's very similar actually for patients with advanced disease, and there have been good studies in that in ALK as well and EGFR, that if you respond, you'll find your circulating tumor cells drop. And it can then be a surrogate for when things may be you know, things may be progressing. And there's normally a lead time on that. But again, as I said, it's not something we would apply in clinical practice. Patients are scanned frequently. And would I switch? Would I jump ship just because I saw positive? No, because of the same premise about oligoprogression or slow progression. I need something convincing clinically or on imaging to jump ship to the next treatment option.
I'm going to interrupt at this point because I know there are several people in the room that have a question for Dr. Baijal, but also I'm conscious that there are some people that need to go. So what I'm going to suggest is that, because I know Shobhit will join us for lunch, so we'll catch him over lunch. So we'll eat while he answers our questions. Same solution to me. So, and then he can, yeah, and then he can eat afterwards. So I think, on behalf of everyone, I know I'm cutting it short, and there are people. I know there were hands that are doing this, but at some point I need to, because people do need to leave. So I'm going to say thank you very much indeed, officially, to Dr. Baijal.